My name's Scott Burnt. I've been in the background on a couple of these Zoom lectures that we've been giving. I'm the Global Health Fellow from the University of Utah. I am a little bit sick right now, so if I cough or sneeze, just bear with me. But this month, we're going to be starting our modules on abdominal pain. And for this first case, or for this first lecture, we're going to kind of have a general approach to abdominal pain, and then we're going to go into two cases. The faster the lectures go will be dependent on how active you all are in answering questions, because I'm okay with a little bit of awkward silence. But if you guys answer the questions quickly, then we can move on and keep the lecture moving smoothly. So without further ado, we're going to get started. Can everyone see my screen, by the way? If you can maybe a thumbs up or throw it in the chat.
Looks good, Scott.
Perfect. Okay, thanks for the thumbs up. So some overall considerations in abdominal pain are going to be one, that abdominal pain is the most common complaint in most EDs. So if you're bored and you want to decide what you want to study in any given day, studying abdominal pain and the different diagnoses is going to be well worth your time. And thus the next 4 weeks, I think, are going to be really crucial to becoming a good emergency medicine physician. Those who are immunocompromised may have minimal symptoms and reassuring vital signs in labs. So, immunocompromised patients have high threshold to get blood work, or low threshold rather, to get blood work, and low threshold to get imaging. Patients who are elderly also have low threshold to get blood work and low threshold to get imaging. The elderly is at significant risk when presenting with abdominal pain. In fact, of those who are older than 65, one study showed that 60% will need admission and 20% of those will need surgery. And of those patients who need surgery, they have a mortality of 4 to 5 times younger patients who have the same type of surgeries. And so time to antibiotics is important. Time to diagnosis is also important. They can really get sick very fast. The tricky thing is that also elderly patients are more likely to have vague and or transient complaints, although they'll still have more significant disease. So don't trust the elderly patient who is telling you that their abdominal pain is no big deal and they want to go home. Take their complaint seriously. And I would, at minimum, do multiple abdominal exams if you're thinking about sending them home. But really, I would have very low threshold and would get imaging on most patients who are older than 65 with abdominal pain. My computer is slightly frozen on my end. Let me give a second here. All right, so a general approach to abdominal pain, just thinking through your differential. I want everyone to think in their head right now. You're walking into a room, patient's 50 years old, and they say they have abdominal pain. Just think about all the possibilities. Your list should be pretty long. And so one way to help break it down, we're going to talk about some locations here in a second. And then also we're going to talk about some things that will masquerade as abdominal pain, but actually aren't from the abdomen. So, like I said, consider what parts and systems need to be included in your differential. And besides intra-abdominal diseases, what else might cause abdominal pain? So think for a second. Some things for me that come to mind would be the thorax, metabolic diseases, electrolyte diseases, diseases of the genitourinary tract, and specifically like the penis, the testicles, um, vaginal complaints, skin complaints. And I have listed down here a couple, so testicular torsion, pregnancy-related pain, inguinal or testicular hernia, myocardial infarction or cardiac pain, pulmonary embolism or pneumonia, DKA. I've definitely diagnosed DKA based on a patient whose chief complaint was abdominal pain. I think that can be a common one. Esophageal disease, so GERD, Boerhaave or a ruptured esophagus, esophageal spasms, and toxic ingestion or exposure. One thing that comes to mind here in the States is black widow spider bites. They often have very tense, rigid abdomen, and that can be their only presenting complaint. And then, of course, skeletal pain, so the spine, the ribs, the muscles. So thinking about them based on location is also pretty useful. So there's kind of these rough entities. You have pain that's diffuse, pain that's epigastric, pain in the right lower, or left lower quadrants. And for each of these, you should be able to list at least five or plus diagnoses. So I'm going to think in my head for diffuse abdominal pain, what can cause that? I want everyone to have a mental practice right now. Can you think of five things that can cause diffuse abdominal pain? And I'll give you a few seconds to think of five potential causes of epigastric pain. Give you guys a few seconds. And what about right upper quadrant, left lower quadrant, right lower quadrant, and the left upper quadrant? So here is a picture. Hopefully you kind of have a mental map of all these things, but you can see how broad the differential diagnosis can be for abdominal pain. Some of the ones that are starred are the big ones. So mesenteric ischemia, we cannot miss that. Perforated viscus, thoracic or abdominal aortic dissection, cholangitis, ectopic pregnancies, ovarian torsion, testicular torsion. The list kind of goes on, and it's pretty broad. Also, you need to consider referred pain. So a patient may complain of shoulder pain, but that's actually masquerading from the diaphragm being irritated by a perforated viscus. They may complain of abdominal pain, but in fact, that's referred from the pneumonia, abdominal pain from the testes, especially in younger males, hip pain from a pelvic source, epigastric pain from an MI. So you really need to have a broad differential diagnosis and try not to hone in on this is run-of-the-mill abdominal pain. Some pitfalls in abdominal pain. Be wary of relying on the white blood cell count. This is often normal until late in a disease process. And so although we'll order it, and if it's high, it can clue us into something bad going on, I would ignore it if it's normal. I would not make that a reassuring thing for you. Pyuria, or finding white blood cells in the urine. This can be caused by intra-abdominal pain, such as appendicitis, and thus be careful diagnosing a patient with a UTI until you've considered other possible causes. A couple other ones, forgetting to consider pregnancy tests in all females of childbearing age. And I would really throw these on for anyone over the age of probably 12. Even if they tell you that they're not sexually active, I wouldn't get in the habit of trusting my patients. And then I would order this anyone under 50, unless you know that they've had a complete removal of their uterus and their ovaries. And then hematuria can be caused by kidney stones, and I like to use that when I'm in the ER. If I see a urine with blood, I often think, oh, this could be a kidney stone, but it also could be a AAA. A kidney stone usually won't cause any serious short-term mortality, but a AAA, they might be dead in the next few hours if you send them home. So be careful with hematuria. And then CT scans, they're usually not more sensitive than 90 to 95% sensitive for most of the pathologies in the abdomen. So a negative CT scan doesn't mean that there's nothing going on. Obviously, you probably won't be able to admit the patient, but if you're concerned they have abdominal pain, I would just have very strict return precautions and tell them like, hey, if this pain's getting worse, you develop a fever, the pain starts to move locations, you start vomiting, diarrhea with blood, you can't have a bowel movement, things like that. They should come back, and it's possible that our first CT scan was just ordered before the pathology was was going to be identified on the scan. Looks
Okay.
like Jane has a question,
I
maybe.
know. This is my first time using the raise hand function.
I like it.
Yeah. The other thing I would say about abdominal pain is when you have very obese people, you can also miss a lot of the pathology, unfortunately. So you actually have to get a very good skin exam. They have so many folds underneath their pannus that I have seen so many missed cellulitis or even just like foreign bodies underneath their, and maybe this is not as common in Vietnam, but underneath their skin folds, just we've had someone when I did residency put a knife in their pannus and you couldn't even see it because it was stuck in their folds. So sometimes it might be hard to do a good physical exam in such a crowded environment, but definitely for your bigger patients, you have to like check all the skin areas. Um, we've had here where people talk about, oh, I lost my pet frog or hamster and it died underneath their skin fold. So that's something, it's just something to keep in mind. I know you guys don't really have as many obese patients. And then the
Definitely.
other, yeah, and then the other thing to also think about is not just like toxic. When we think about toxic things, we think about overdoses of medications and whatnot. But there are other, even everyday medications that are more benign that we might have to go over to figure out why they're having abdominal pain, right? Like metformin, very common medication. Some people do not tolerate it and they do get abdominal pain, discomfort. Um, our GLP-1 medications also for diabetes also frequently cause um, abdominal discomfort. So it's also important to kind of look at their current medication list, even if they're not taking it in toxic or overboard amounts. So that's just other things to keep in mind.
Thanks, Jane, for your input. Yeah, to add along the skin exam, you can find shingles as being a common cause of abdominal pain. And if you don't lift their shirt up and look, all you did was press on their abdomen, you might not notice. So definitely expose the belly, look everywhere, press everywhere, and include the GU region. So don't be afraid to get a chaperone or put a blanket and look at their testicles, look at their vaginal folds for abscesses, testicular torsion, stuff like that. All right, moving forward. Um, oh, this was just a good example of have CT scans. One study showed that 1 out of 20 patients with appendicitis didn't have CT evidence of appendicitis, and they were not found to have appendicitis until they bounced back to the emergency department the day or two later, which is pretty high. I mean, that's going to happen at least once a year, probably, if you're in a busy ER. um, just for you alone, you're going to see 20 appendicitis cases probably a year, and you're going to send one of those patients home unknowingly because the CT scan was normal. So strict return precautions are huge. Okay, so we're gonna move into some cases. I think this is the best way to learn, and so I wanted to spend our time here. We have two cases, and then we have some pearls at the end as well. Hopefully, we'll have time to get to. If we want, we can. I would love a volunteer, and I promise not to pick on you, and we can help along the way, but to kind of pretend like you are the physician and you're gonna walk into a room. I would love a volunteer to start the new year off right. I promise it won't be that, it's not that hard of a case. You'll nail it. Any takers? All right. Whose birthday is in January? Anyone's birthday in January? Nobody. How about any birthdays in December last month? All right. February? Any February birthdays?
Uh, my birthday is February.
Hey, mine too. So your gift
Oh,
for your birthday in February is you're going to get to run this case and you're going to remember these details and you're going to be a better doctor for it. So, um,
okay.
I can hear you pretty well, so that's great. Case one. So here's your chief complaint. It's a 22-year-old female. She presents with abdominal pain. You get a set of vitals from your nurse who got a heart rate of 105, a blood pressure of 115 over 70, a respiratory rate of 18, oxygen's 100% in room air, and a little febrile at 38.1, and that's degrees Celsius. So before you even see the patient, what can't miss diagnoses are you thinking about? And then how are you going to address them? I won't make you elaborate on the address part, but just what are like 5 things that you want to be, I do not want to miss in this young female patient.
Okay. So first of all, this this patient is a young woman, so she's in uh, the period period of
Yeah.
yes. So wouldn't why I wouldn't want to miss the ectopic pregnancy, although she has slight fever, so it is very uh, 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 I would think about that much, but yeah, I wouldn't want to miss that diagnosis. Uh, and secondly, mm, maybe what else?
Yeah, you mentioned fever, so you're like you said,
Yeah.
you're thinking about things that could cause a fever and abdominal pain.
So
So
there is many diagnoses that can cause both fever and abdominal pain, including uh, gastroenteritis,
yeah, perfect.
and also what is called like the infection of the uh, high urinary system.
Yeah,
Yeah,
like
like
pilot kidney
kidney.
infection.
Yeah,
Perfect.
yes, yeah, and yes, also uh, the perforation of the gastric and the enter the bowel
Perfect. I
also
like
may
it.
cause abdominal pain and fever.
Perfect. So based
Mm.
on those things, sounds like you're getting blood work for sure. You're probably gonna get a pregnancy
Yes.
test for sure. You're getting a
Mhm.
urine for sure. And then we'll have to decide on what kind of imaging. But you're already halfway there. So thank you. Good job. So we'll move forward. You walk into the room. The patient appears to be uncomfortable. They're holding their arms across the abdomen, but they're able to carry on a conversation, breathing normally. So here's your HPI. As a 22-year-old, the abdominal pain started yesterday. It started in the middle of her abdomen and then has progressively worsened throughout the night. The pain now is migrated to the lower part of her abdomen, more so on the right. Pain is sharp and 10 out of 10. It's worse when she moves around. Do you have any questions for the patient so far?
So so the system is very suggestive of the acute appendicitis. Um,
Definitely concerning for that. I think
yeah,
some questions that I would want to know about I would keep your initial differential in mind, and so I would ask her about urinary symptoms. Does it hurt to go pee?
yeah, definitely. Yeah.
Is there blood in your
So
urine?
so, so
Yeah,
mm,
yeah.
yeah, yeah, yes.
Um, you know, have you had any diarrhea? Is there blood in your stool? Because this could also still be gastroenteritis, like you initially said, or perforated GI. um, nausea, vomiting, stuff like that. And so just some more information. The pain is associated with non-bloody, non-bilious vomiting, and she's not been eating as much. She denies any abnormal bowel movements, and she's unsure of her last menstrual period. So, like you first mentioned, ectopic pregnancy is still definitely a possibility. Moving forward, she doesn't really have a past medical history. She's been healthy, no previous surgeries. She's allergic to Bactrim or TMP-SMX. She's on birth control, otherwise no medications. And then she denies alcohol, smoking, or drugs. She's in college and sexually active with her boyfriend. Uses condoms for pregnancy.
Mhm.
Oh, and then for your physical exam, what are you looking for? Part of it was on the screen there for a second, but what are you gonna do for your physical exam?
So definitely the most important thing about abdominal exam is palpation. So you so I would want to palpate her abdominal very carefully, looking for the resistance of the abdominal wall. and looking for the some specific tone of pen like the McBurney tone, the McBurney site, yes, for
Perfect.
appendicitis. Yeah,
Nice. Nailed it. Nailed it. Yeah, that's the biggest one for appendicitis is definitely McBurney's point. But like you said, doing a thorough exam, still considering all other possibilities. But yeah, so her physical exam is normal except for her abdominal exam. It was abnormal. She had rigidity and rebounding of the right lower quadrant and really just diffuse abdominal pain throughout. And she had a positive Rosing signs. And we'll talk about some of the signs here in a second. So we've kind of gone through your differential as we went along, just to throw up some on the list that we've talked about, just to remind everyone. And then for her too, pelvic inflammatory disease, I would throw on my list, or tubo ovarian abscess, just because of her sexual history. She certainly
yeah,
could be at risk for that. But you mentioned these other two main ones. We talked about a kidney infection, ovarian torsion as well. And then these are some other things to consider, but like you've kind of mentioned, it doesn't sound like it's these other things, but these are things that maybe initially went through your head. So next steps, you're probably going to want to get blood work, imaging, maybe give some medications, and then possibly thinking in the future, like, will I need to consult somebody? So we'll skip the blood work part, or I'll just throw that on the screen. Um, But based on this, so far what we found is she is tachycardic, she is febrile, and she does have signs of peritonitis. As you elicited on your physical exam, she does have that
yeah.
rebound and point tenderness with guarding of the right lower quadrant. So we'll make the patient NPO. We got some other people joining us. Welcome. Here's maybe some blood that you're thinking about. CBC, a CMP, PT-INR, because you're thinking this patient might need surgery. So you're thinking that plus a type in screen, the urine pregnancy, lactate lipase. Blood cultures plus or minus. I think I would definitely get them if I was thinking this patient looked sick enough to need antibiotics. But at the moment, I think plus or minus on that. And then also the CRP ESR. Depends how often you use that. It can be helpful if you're considering not obtaining imaging, if you have a normal CRP and ESR, that can maybe lead you against something dangerous going on. But in this patient, I don't think it's going to make any difference. We know this patient is pretty sick based on her exam and vital signs. So I probably wouldn't personally order a CRP and ESR, but those are available to you. I'm wondering for you, what kind of imaging would you normally get in Vietnam for this patient?
So we definitely want to give her an ultrasound uh, for the first imaging that we will use.
Perfect. Yeah,
Yeah.
I think ultrasound would be awesome. In a young, healthy 22-year-old who is thin, um,
Yes.
we could probably, if we're worried about appendicitis, that would definitely potentially be the right thing. I think a CT scan would be a reasonable choice as well if you didn't have ultrasound available, or if you were considering other diagnoses besides appendicitis and you wanted a more global evaluation of the abdomen. Um, Yeah, so if access to it, consider appendix or pelvic ultrasound if you're considering ectopic pregnancy. For meds, I think this we can kind of fly through this. You'd probably give a liter of fluids, some kind of pain management, some kind of anti-nausea meds. She did have a fever, so I would recommend acetaminophen. And then IV antibiotics, I would probably recommend given she is febrile and tachycardic. And then you could consider a gen surge consult just due to how your exam, but I would probably wait at least until the pregnancy test was back, as she may actually need an OBGYN, not a general surgeon. We're not sure what our
Mm.
pregnancy test is yet. All right, so if you could just quickly the high points on this blood work, we can look at all these. What stands out to you?
Uh, so we can see that she had a really significant patient with very high white blood cells,
Yeah,
And
perfect.
I'm looking for CBR or mm,
And her pregnancy test is not on here, but it's
uh,
negative.
yeah. So the lipase is not elevated. So so we won't consider she had pancreatitis.
Perfect.
So
Yeah.
yeah.
Yeah. So I agree with you. Really, the only thing that jumps out is she has a high white blood cell count.
Mhm.
So in this case, we'll look at some ultrasound images in a second too. Here's a CT scan. Do you notice anything different from right to left?
The right side, I noticed there is some I'm not sure how to describe in English. Sorry.
Yeah.
Yeah. So it is more dense. It
Yeah.
uh,
Perfect. Yeah. I mean,
you
you're
can see
noticing
some fat.
the different fat stranding.
Yeah,
Yeah.
yeah, fat
Perfect.
stranded. Yeah, yes.
Yeah.
In
So
the left.
here's some arrows to help. Yeah, so you mentioned this
Mhm.
this asterisk, the red star here, that's showing like a lot of inflammation and fat stranding. The blue arrow is pointing to actually a little appendicola. So that's in a little stone inside the appendix.
Mhm.
Or really it's hardened
Yeah,
stool. And then the yellow arrow, the dotted yellow arrow is showing to some free air. That's some air that's not inside the colon. So that's air that's outside the colon, which is concerning um, for a ruptured appendicitis to be specific.
yeah.
So awesome. We got the diagnosis. Um, Great job. Thank you again for volunteering or having a birthday in February. I appreciate it. So
Thank
case
you, thank you.
summary, I'll
You
do this
too.
part. It's a perforated appendicitis causing sepsis. The patient did meet sepsis criteria based on her vitals. And leukocytosis and so thus we wanted to start early fluids, obtain blood cultures, and start antibiotics. She did have peritonitis, so an early surgical consult would be considered. And some physical exam highlights for appendicitis are McBurney's point, which you mentioned to us, and that's pain in the right lower quadrant. It's between the pelvic rim and the belly button, so it's 2/3 of the way down. That's the most classic location of pain for appendicitis. Some other signs that you can do, but they're not always present, are the Rosin sign. And so that's when you actually press on the left side, but you have pain on the right. So it's pain on the opposite side. The psoas sign, and this is pain when you extend the right leg. And so the psoas muscle, as we'll see when we look at the ultrasound imaging in a second, the psoas muscle lives directly next to the appendix. And so when you stretch that muscle, it presses or moves the appendix. And the obturator sign, just anterior to the pelvis is the appendix. So it's the same thought. As you internally and externally rotate the hip, you're going to be moving the tissue around the appendix. And if it's inflamed, it's going to cause pain. So those signs, the more important thing is not to memorize the names, but to understand the anatomic relationship between the appendix and its surrounding structures. So some other continued pearls. Can labs help with diagnosis? The short answer is probably not. But in the pediatric population, where you're not that concerned, but it's on your differential and you want to avoid radiation, you could get a white blood cell count, including a CRP. And if everything's normal, including the neutrophils, so you have no shift of the neutrophils, you can probably safely rule out appendicitis and avoid radiation. Of course, if you have ultrasound available, then that's also a good way to go. And can we use ultrasound? And it sounds like you guys know the answer to this. But ultrasound should be our first choice in pregnant patients or pediatric populations, but it can also be used in older adults. It really loses its sensitivity as the patients are gain weight. So this is best in a thin patient who haven't had prior surgeries, and their anatomy is pretty straightforward. But if you don't find the appendix, you might have to get a CT scan anyways. But one study showed that you could find the appendix and avoid a CT scan in about half of the patients with right lower quadrant pain. Of course, sometimes right lower quadrant pain isn't appendicitis. Sometimes it's nothing at all. It's maybe a viral illness. Sometimes it's ectopic pregnancy, an ovarian complaint, kidney complaint, a testicular complaint. And so sometimes the ultrasound is not going to find the appendix because it's actually something else you're dealing with. MRI is also something you could use if that's available to avoid radiation in a pregnant patient. And then antibiotics. This is going to be a little bit determined by your local infectious disease and general surgeons, what their preference is. But in general, you want to cover for aerobic and anaerobic gram-negative organisms. And if it's complicated, like our patient, I would consider her complicated. It was perforated, and she also had signs of sepsis with the tachycardia and fever. I would also want to cover for Pseudomonas. So with Pseudomonas, you can choose Zosyn or you can add ciprofloxacin, but otherwise the most common is probably metronidazole and a cephalosporin of your choice. Like ceftriaxone's common, but cefoxitin is common too. Really any third or fourth generation cephalosporin would be fine. And then this is something that kind of comes up a little bit in America, and I know in Europe it's pretty popular, and that's to use antibiotics alone. This is definitely possible in the right scenario, uh, but it's not probably something we need to spend too much time thinking about because these patients are going to be admitted and you're going to consult surgery no matter what. And so it's really going to be up to the admitting team or the surgical team if they're going to do surgery. But it's something to know that can happen. And in the largest study, patients with antibiotics alone, they did similar in the short term, but then within the next year, about a quarter of them ended up needing surgery anyways, due to like an abscess or recurrent appendicitis. So unfortunately, if you don't remove it, you can get appendicitis more than once. All right. So that's the end of case one. Any questions? Or did anyone have a recent case of appendicitis? Any good learning points from that or any weird presentations?
I I think something to keep in mind is that sometimes you will have patients that have a paradoxical or relative bradycardia, even when they are hemorrhaging into their bellies, um, which we have seen, or at least I've seen in residency, and it became an M&M. Um, Generally, we might think of this in terms of like, oh, maybe our old person on a beta blocker, and maybe that's why they're not having the tachycardia response. But even in young patients, with our ectopic pregnancies, with the free fluid in the blood, um, there's a belief that there's a vagal response to it, the irritation of the blood in the abdomen. And in turn, that's why they don't have the expected tachycardia, even though they're hypotensive. So that's just something to keep in mind. I don't know when the last time you guys saw this was, but that's something to be aware of.
Yeah, I have seen that myself. I think it was probably a year ago or so. But yeah, had a patient who was like 55, 60, but otherwise had signs of sepsis and they had a perforated appendix and the surgeon came down and was like, oh, they must have blood causing the vagal response. So it does happen. That's a good one. Okay, it's case two. Thank you, Jane. Any volunteers for this case? All right, we're going to continue with the birthday game. Any birthdays in March? Any March birthdays? Or Dr. Fook, please feel free to call somebody out. You can choose the next person since you had to go.
I'm not sure if uh, can Dr. Hải Phương Nguyễn, can you do this the second case with Dr. Scott?
Doctor, when are you there?
Mm.
Maybe the audio isn't working for them. All right. Well, next time we'll call on someone and make them go. We'll just fly through this case and then we'll look at some ultrasound images because I do want to make sure I don't keep you guys over. But yeah, so case two, this is going to be a case of a 67-year-old female. She presents with abdominal pain, nausea, and vomiting. Her vital signs, heart rate of 115, a blood pressure of 90 over 68, normal respiratory rate, 96% on room air, temperature of 36.9, and 88 kilos. So a little bit on the heavy side, but not terrible. She's uncomfortable. She's diaphoretic, sitting on the gurney, eyes closed. And so she appears pretty sick. So you start astutely. You just want to make sure everything's okay. Her eyes are closed. So you do an ABC actually. You go straight to a quick physical exam, given the tachycardia and the hypotension. And her ABCs are thankfully pretty reassuring. She's able to speak normally, no respiratory distress with clear lungs. And her circulation seems to be pretty normal, 2+ distal pulses, and she is warm. So your differential is obviously pretty broad, but you have a patient who is meeting sepsis criteria and likely has a source in her abdomen. So some next steps, these are kind of generic, but you want to get 2 IVs, place them on the monitor, potentially if you have room for it, or get a nurse to come start drawing blood work, starting IV fluids while you obtain your history and physical. Obtain a glucose. Certainly DKA could present as nausea, vomiting, tachycardia, and hypotension. Depending on ultrasound skills, you might perform a rush exam for, and does anyone remember the steps of the rush exam? Or does anyone remember what rush stands for? I don't think we've talked about the rush exam formally during this year, but we will at some point. So just as a quick introduction, the rush exam is a set of exams done in patients who have shock or hypotension. And so it stands for the rapid ultrasonographic assessment of shock and hypotension. And there's a mnemonic to help us remember which things to ultrasound during this exam. It's HI map or high map. Um, and that's going to be the heart is the H, the I is the IVC, the M is Morrison's pouch, which should prompt you to do the rest of the FAST exam. So the Morrison's pouch, if you remember, is the part between the liver and the kidney. And then the A stands for the aorta. So you're looking for an aortic aneurysm that's possibly ruptured. And then the P is looking for pneumothorax. So just quickly, there it is for you. But a patient who is hypotensive and you don't know why, this is something you could consider doing to look for the rapid and reversible causes of hypotension. Of course, sepsis you might not be able to find, but that would be the kind of the big category not assessed by this. So the case to continue, the HPI, like I said, is a 67-year-old. She has diffuse abdominal pain. It's most severe at the center of her abdomen. The pain started 2 days ago and has been gradually worsening. She feels quite bloated and nauseated. Since the pain started, she has had very frequent non-bloody but bilious emesis. And this is a big clue and a good reminder to ask about the vomit. Is it bloody? Is it bilious? What are the contents? Is it dark, coffee ground, stuff like that? Um, let's see. She denies any fevers, chills, diarrhea, no pain with urination, and no chest pain. She does have a history of hypertension, hyperlipidemia. She is a diabetic. And she does have a history of an incisional hernia. Surgical history, she had an exploratory laparotomy after a car accident 10 years ago. No allergies. She's on a few medications to address her hypertension, her high lipids, and her diabetes. Social, she drinks a glass of wine, smokes a quarter of a pack per day, so about 5 cigarettes per day. No drug use. Of course, next you'll do a physical exam. As mentioned, she's in moderate distress. She's in pain. She's nauseated. She has dry mucous membranes. She's tachycardic. Her lung exam's normal. In her abdomen, it's distended, diffuse guarding, and she has a large healed midline incision with an incisional hernia that is firm and tender. Otherwise, her exam's normal. Um, any volunteers for a differential diagnosis? Or if you think you have the
Yeah,
diagnosis nailed, that would be helpful.
uh, based on her history, I'm thinking of bowel obstruction, and I'm also concerned for acute pancreatitis or acute cholangitis.
Perfect. Yeah, I think those are great. Um, I think, and then you could
And
add to
also
all those.
triple A.
Yeah, a triple A too with the diffuse pain. That's good. Perfect. So with that differential in mind, our next steps, what is everyone doing for next steps in this patient? As far as medications, as far as what tests do you want to order, or maybe any actions? The one thing that we mentioned was that there was a hernia that was firm and tender.
This patient show sign of sepsis, so I definitely want to give her some IV access and maybe fluid bolus initially. In terms of test, I would want to do complete blood count, PT and INR, since she may go under an operation, and I would do an ultrasound, the focus for uh, as you could say, for finding so the cause, and if it is unclear, I may uh, if the her her blood pressure is stable, I may give her a CT scan with contrast, and then consult with surgeon.
Perfect. I like it. I like it. Let's get those steps on the screen here. So labs, I think you mentioned all of these. So awesome job. Yeah, imaging, CT versus X-ray versus ultrasound. I think starting with something at the bedside, since at the moment she was maybe unstable, but after the first IV fluid bolus, maybe it could become stable. Blood pressure could improve, and then maybe go to the CT scanner. Let's pretend in this case, she did not improve. Her blood pressure remained kind of hypotensive, 80s over 60s, still in a lot of pain and still tachycardic. And the CT scanner wasn't even available anyways. So maybe we do a ultrasound and a bedside X-ray, which we'll look at in a second. Like you mentioned, starting with some fluids, to treat her symptoms as well, make her feeling better. And then IV antibiotics, maybe a question mark. Um, I think would probably be safe to start it, but if you want, I think if she improved after fluids, you could consider holding off. And then reduce the hernia. It's something to think about. We'll talk about more later the pros and cons of the hernia and when to reduce it, but that's something definitely we need to be thinking about. Here's her blood work. Most notably, I'm noticing a little bit of a bump in her creatinine, so suggesting that maybe she is in shock. She does have a white count that's quite high. Um, her urine's pretty unremarkable. Lipase is normal. Her liver enzymes seem pretty normal as well. So less likely maybe to be hepatic, gallbladder, or pancreatic origin. That upright X-ray does come back. Does anyone recognize what this could be, or does this look normal to you guys?
It look like she has she had the intestinal obstruction. Uh, Specifically, this this kind of imaging on the right side is suggestive of small intestine obstruction.
Perfect. Yeah, you nailed it. The key is making sure you're getting an upright X-ray or lateral so that you can see the air fluid levels. This is actually two different patients, but they both have the same disease. They have a small bowel obstruction or a small intestine obstruction. And you can see that you have these very discernible air fluid levels, and you have a widened small intestine. Um, and the 2.5 centimeters is the magic number that you could measure if you had the ruler on your screen. Here's what your ultrasound would show. Same disease process. Again, we can see a colon, and if you measured this, this is greater than 2.5 centimeters. In this case, on that I'm hovering on the left of your screen, you can see surrounding fluid, which is suggestive of just inflammation and potentially bowel necrosis or ischemic bowel. And on the right, again, you're seeing actually multiple loops of bowel next to each other, which is rare, and you shouldn't see that. And you can also start to see the plique here, which in normal bowel you can't see on ultrasound. So this case, you guys nailed it as far as a small bowel obstruction. In this case, it was caused by an incarcerated and strangulated hernia. So that was the cause of it. And it was critical in this case to develop a broad differential, recognize the hernia, but do not reduce, obtain imaging, start fluids, antibiotics, and consult surgery for definitive management. So some obstruction pearls. First, the types of hernias. There's three main types. There's reducible hernias. These usually don't end up in the emergency room, at least not as a chief complaint. Most patients have hernias that are reducible. They come and go throughout the day, might come out when they're defecating or straining during a bowel movement, and then they're able to go back in. These should not be painful, and they should be pretty easy to push back in. Then you have incarcerated hernias. These are often hard and painful to palpation. On initial evaluation, these might not be reducible and may be difficult to push back to the hernia by direct manual pressure, but with adequate analgesia and time, you might be able to get these back in. And then lastly, you have strangulated hernias, which these occur as a consequence of incarceration. Oh, sorry about that. Where there becomes an impairment of blood flow to the hernia contents. These are a surgical emergency. You'll often see skin changes on the outside of the wall. You might see erythema or something that looks like necrosis. And on ultrasound, you'll often see a lot of edema. If you use ultrasound, you'll be able to find that there's colon inside the hernia, and you can put on the color flow. You'll see limited color flow, and you might see edema and fluid around the hernia. So just to hit on the treatment again, obviously if they're reducible, that's pretty easy to do. You might consider sending them home with a binder or a belt to help keep the hernia in place, considering stool softeners so that they don't develop worsening hernias, and also an outpatient surgery appointment to discuss potentially correction of the hernia. If it's incarcerated, but you don't think it's strangulated, maybe they have normal labs, it's not that tender, there's no skin changes, and on ultrasound, you can see color flow in the hernia contents. You could apply some cold packs, place the patient in a steep Trendelenburg, so put their head down, their legs up, take the weight of the abdominal contents off the hernia, come back in 20 minutes, give them some fentanyl. You might be able to push it back in. Some tricks is actually to elongate the hernia first. So before trying to just smash it back in, actually try to elongate it. And that way you can find the base of the hernia or the most proximal portion of the hernia and push that part in first. If you do get it reduced, you might not want to send them home immediately because it might just pop right back out. Or it's possible that although you've reduced it externally, there's still a hernia on the inside. And so they may still have a lot of pain and might still need further imaging or surgical consultation. If you think the hernia is strangulated, do not attempt reduction. This could reintroduce ischemic bowel, which could lead to perforation and sepsis. If it's strangulated based on CT imaging, ultrasound without color flow, an elevated lactate, or skin changes, do not reintroduce or do not attempt reduction and consult surgery ASAP. The causes of a small bowel obstruction, most common is adhesions from prior surgery. So if someone's had surgery ever, that doesn't have to be recently, they've had adhesions and could be at risk. Consider hernias, cancer, a stricture from ulcerative colitis or Crohn's disease. And these can be sometimes intra-abdominal hernias or intussusception that lead to SBO. So you can have complicated diverticulitis that eventually forms an abscess or perforation that leads to a small bowel obstruction and then volvulus. As in this case, the patient will usually have a history of constipation. They're not passing gas. They have diffuse abdominal pain with distension. And distension is the most reliable exam finding in small bowel obstruction. They'll have a history of surgery and they'll have vomiting, which could be bilious. And if it's a large bowel obstruction, the vomiting could actually have fecal contents. So they could actually be vomiting up some poop. Pretty gross. Diagnosis and treatment. CT with IV contrast is the gold standard and can not only show the small bowel obstruction, but can often show the cause of it and any associated complications. If CT is not available, you can use X-ray or ultrasound. You want to treat with pretty aggressive fluid resuscitation. These patients haven't been eating due to their pain. They've also been actively vomiting and losing fluids due to the decreased absorption and fluid loss from bowel ischemia. Give antibiotics early if they're unstable or if there's any evidence of bowel perforation or bowel necrosis. And then NG tubes, although they're often unnecessary, the general surgeons often like them. And so I would just talk to your general surgeon about placing them. There have been multiple studies that show that NG tubes do not change patient-centered outcomes. But if a patient is persistently vomiting or have severe distension, they can be helpful. But they're definitely a painful procedure. So please give your patients some kind of medication to help. Fentanyl is pretty helpful, or I actually like to use a benzodiazepine. So I'll usually give like a milligram of Ativan, as I think a part of the pain with NG tubes is just the anxiety of having someone shove a tube down your nose. And so if you give them a Ativan, they're going to be less anxious and they'll relax, which makes the job easier for the nurse and makes the tube pass a lot easier for the patient. So I promised that we'd talk about ultrasound a little bit. In both small bowel obstruction and appendicitis, you can use ultrasound to rule either diagnosis in, but be really careful ruling out these diagnoses with ultrasound. If you don't find it, it's possible that it's there and you just missed it. Additionally, it's difficult to use the ultrasound to assess for a complication of either disease. So you might find appendicitis, but you might not notice that there's a part of it that's perforated or that there's an abscess associated with it. Or you might find the small bowel obstruction, but you miss the large cancer that is the cause of the obstruction. In thin patients, you could probably use the linear probe, and that's going to give you more detail. But in most patients, you're going to want to use the curvilinear to allow for more depth. And just keep this in mind. As I mentioned before, the appendix is next to the psoas muscle, and it's anterior to the iliac artery. And so if you find the artery, that can help you trace the artery up and down, and then you'll find the appendix. So a small bowel obstruction, you'll find a fluid-filled bowel measuring greater than 2.5 centimeters. This is also the same cutoff used on X-ray and CT imaging. You can see fluid, really it's poop, but you can see the fluid going back and forth. It's called the to and fro sign, as opposed to one direction. I would actually say this is pretty easy to do. Most likely your surgeons are still going to want the CT scan, but this is not a very difficult skill. Whereas I think finding appendicitis reliably can be more difficult. You can also use the ultrasound if the hernia is the cause of the small bowel obstruction. You can figure out what's inside the hernia. Is it just fat, or is it fat plus colon? You can find the defect in the fascia, and thus it'll help you decide which direction to put the pressure so you can reduce it more successfully. Here's some examples of a small bowel obstruction. You have a dilated loop of bowel. As I mentioned before, you can see the keyboard sign, which is the fact that you can see the plicae circularis, which you shouldn't be able to do. That's that yellow arrow there on the left side of your screen. And then on the right side of your screen, you can see a couple of signs. One, you can see that the colon itself is greater than 2.5 centimeters if you measured this out. But you can also see that the wall is really thick on the top portion of that. So you have the bowel contents, and then above that, you have a thick wall. And so this is likely, there is probably some ischemia going on and possibly necrosis. And then inside, you can see all these specks. And if this was a video, you'd see those specks going back and forth, right to left. And that only happens when there's an obstruction downstream, that when the colon is contracting, it's not allowing the fluid to move in one direction. And so it goes back and forth. Appendicitis. Here we go. This is the first choice for pregnant women and children. I think it's a little bit harder. So this is definitely operator dependent. Patients who are really large, the appendix can be quite deep, and it's quite small. So it can be hard to find in in the sea of fat and tissue. And there's colon, and there's the gas from the bowels can get in the way. So this can be a little bit harder. What you'll find, though, is a non-compressible appendix. Remember, the appendix is normally a hollow organ, and so it should be very easily compressed. If you can't, then that's concerning. You could see this target sign where you have fluid around the wall that makes it look like it's a target. So that black on the outside is actually fluid, and then that outer white rim is the normal wall of the appendix with a appendicolith on the inside. You can measure it if it's greater than 6 millimeters, that's concerning. Or if the wall is greater than 3 millimeters, that's concerning. So it could either be just the wall or the entire appendix that could meet the criteria to be appendicitis. You could see fluid around it. You could see the appendicolith, and you then should get some shadowing, which you can see just a touch of shadowing here. You would see it probably more if this was a video. And here's a couple other images of appendicitis and also some tricks to find it. So on the top part of the screen, the AP is standing for the appendix. So that's this here. Next to it is the psoas muscle. Underneath it is the iliac artery and the iliac vein. And so the appendix is anterior to those vessels. And then on the bottom, this is just a longitudinal. So you just turn your probe 90 degrees up and down. And so you get the appendix in a transverse view. And then underneath it, again, is the artery. Underneath that's the vein. And here you would, if you had the probe in your hand, you couldn't compress this. If you measured it, it'd be greater than 6 millimeters. And in both scenarios, you get a little bit of a target sign where you're seeing fluid from the edema, the wall, and then the hollow organ with the appendicolith on the inside. So that's the end of the lecture. Thank you, everyone, especially those who volunteered to give us some answers. I really appreciate it. It makes my job a lot more fun. Any questions or feedback? Or again, did anyone have any good cases recently of a small bowel obstruction, appendicitis, or anything abdominal related that they would like to share so we can learn from you all? Myself included. Would love to learn from you guys. All right. Well, a quick shout out to 5 Minute Sono or the POCUS Atlas if you want some more training on ultrasound and you just want to spend like 5 or 10 minutes. Both these websites, one's the Sono on the top is 5 Minute Sono, the first resource listed. It's video format if you like to watch videos. The one below it is a series of images and like video clips, then with explanations. And that's pretty nice if you want to kind of read the information and digest it at your own pace. I kind of prefer doing it that way at first and then using the 5 Minute Sono as a refresher. Of course, Corpendium has a lot of good info as well. But yeah, thank you guys for your help. Jane,
Awesome. Good lecture, Scott.
thank you, everybody. Have a great Happy New Year, and I'll see you guys next week.
Thank you.
Bye.
Happy New Year.
Oh.